The question really becomes, and the crux of the controversial issue is whether or not a course of post-operative antibiotics is necessary, and does that help?
Hello to another of the Rhinoplasty podcasts. Today I'm very excited to have one of our young guns all the way from Denver, Colorado in the USA. This young gun started med school in Wisconsin, and I've met him numerous times. I had the pleasure of having him in South Africa at our Saucer Congress in Durban in 2019, and then we had the most delightful safari afterwards. And I'm so inspired by him. I'm inspired by his absolute passion for breaking down difficult concepts and teaching them so well. He also is so relevant in what he speaks about. So today's program about antibiotic prophylaxis and rhinoplasty is brought to us by Vectra from Canfield Scientific. Vectra make, I think, some of the most unbelievable 3D cameras, and we can use these images to morph and show patients and plan our surgeries. So I already enjoy using Vectra in my practice. And without any further ado, Professor Andy Winkler, welcome to the show.
Oh, thank you, Cam. It's so nice to see you and talk to you again. I think the last time I really saw you is in South Africa, and it was such a wonderful opportunity to visit your country. And you were a wonderful host, and gosh, we had such a good time. It was awesome.
Yeah, my only regret is that you had to leave your sons behind. It was just you and your wife who came out.
Yes, man. Maybe next time.
So Andy, I know that, apparently you do rhinoplasty, but I think you spend more time skiing than you do rhinoplasty. But I guess if you live in Colorado, you have to.
I wish I did. No, not so. Unfortunately, it's hard to find time to escape up to the mountains from Denver. But as many of your listeners may know, Denver is ideally situated for hidden resorts like Vail and Aspen and everything else. And gosh, we love it. We love skiing.
And Andy, you strike me as a passionate guy. You're very passionate about teaching facial plastic surgery, not just rhinoplasty. You're passionate about your family. You love the outdoors. Are there other things that you get up to when you're not working?
Yeah, we like to climb mountains in Colorado. So one of my passions is to complete what are called the 14ers here in Colorado, and that is the mountains that have at their highest elevation over 14,000 feet. So there's 54 of them here in Colorado, I believe 54, and I think I'm up to about 20. So during the summers when you can't ski, we climb these mountains and we enjoy every minute of being outside. It's great.
Wow, man. I've just finished the 2 different books on Mallory and Irvin climbing Everest, and that was fascinating. And we don't have mountains like that in South Africa.
Well, I was actually very surprised when I was in South Africa how many mountains you do have. I didn't realize it was quite that mountainous. It's quite a different kind of. You have every kind of environment in South Africa, don't you?
Yeah, we do. And when it snows, it's on the national news. It's quite something. Anyway, okay. Andy, let's climb into this a bit more. Tell me, how did you end up being where you are now in your career?
Well, I guess, Cam, the reality is that I always knew I wanted to go into academic medicine. It was a passion of mine from the very beginning, and I always enjoyed doing research and thinking about problems very in depth and trying to figure out an answer to them, and as well teaching. So it was always kind of a natural fit for me. So after my fellowship at Oregon Health Sciences University, it was really a matter of just seeing what academic job fit me the best. And I had the opportunity to come to the University of Colorado. And at the time, there was really no one else doing facial plastic surgery in Colorado at the university. So it was an opportunity to kind of build it from the ground up. And since then, we've hired 2 of our former residents who've gone on to do facial plastics fellowships. Business is booming, and we're really making some good headway in Denver and the rest of the United States. So, that's been very exciting for me. It really motivates me, and I enjoy doing that. And I guess it's kind of how I ended up where I am.
Oh, that's awesome, man. We don't yet have that in South Africa, but facial plastic surgery is going to one day hopefully be a speciality for us here. So
I think it will.
I want to climb into this topic that I think is so relevant about antibiotic prophylaxis. Before we go into the more clinical side to speak to colleagues about it, if a patient sees you, what do you tell them about antibiotics?
Well, I try to be as truthful as I can. Not everybody needs antibiotics, but some people do. I'm sure, as you know, Cam, there's patients who come in and they're like, listen, I had this, foot surgery and I got an infection and therefore I need antibiotics for the rest of my life, for everything. So it runs the gamut in terms of like what kind of patients are looking for. Some of them really, really want antibiotics for everything. Some don't want anything to do with it. So I just kind of try to tell them the truth of where I think they lie in that spectrum of needing antibiotics, before or after surgery. Of course, it depends a lot upon what you plan to do, and of course their medical history and so forth. So it's not a one size fits all by any means, but it is a conversation I try to have openly and honestly.
Okay, well that's great. Okay, Andy, let's not climb into this thing. So here I am. I want a rhinoplasty. I've come to you, and I'm your colleague. Okay, so it's slightly different now. So now start telling me about why we should or why we should not use antibiotics as prophylaxis or as treatment or as post-treatment in rhinoplasty and facial plastic surgery.
All right. Well, so first of all, I think talking to you is more of an expert in the field, but also to my patients. No one wants a surgical site infection. No one wants an infection after a rhinoplasty. These are costly endeavors, and the cost. There have been studies that looked at the cost of getting a surgical site infection, and the cost of a first hospitalization is about $3,000 US dollars. And then if you actually have to be readmitted after you've been discharged, that cost goes up to $5,000. So not just to mention, that's just the dollars and cents part of it. But of course, an infection in the nose carries a risk of, ascending infection, as we talk about, that goes through the veins into the intracranial spaces, and it could be associated with, even mortality. Not saying that happens very often in modern medicine, but it certainly has the potential. But then there's other things to consider of the costs of a surgical site infection in the nose. And that is, patients are going to have longer downtime with an infection. They're going to have worse results. That can affect your practice as a surgeon. Certainly of word of mouth when patients, speak to their friends. And then, of course, just the requiring revision surgery, which nobody wants. So all of these things come into play and are considerations of how do we prevent surgical site infections, because they are a big burden. The question becomes well, how do you prevent them? So I think it's realistic to say that everyone will need some sort of antibiotic therapy during a nasal procedure like a rhinoplasty. The question really becomes, and the crux of the controversial issue is whether or not a course of post-operative antibiotics is necessary, and does that help? And so that's where I think kind of the debates can be had. Although I don't think there has been a lot of good studies to kind of settle this, but I think there's a case to be made that one needs to be done.
Absolutely. Just pausing there for a second. Just over 3 years ago, I had a nevi cut out the side of my head. It was in the way of my microphone.
Right. I remember this.
And I didn't take any antibiotics, and I actually ended up getting sick and getting a cavernous sinus thrombosis and ending up in the ICU. And the silly thing was that I think it comes down to the fact that if I had one course on the day of surgery, it probably wouldn't have happened. But secondly, there were so many of us specialists involved that we didn't see it, because we as doctors often are so focused on our patients that we forget about ourselves. So for me, there's a lot of that kind of emotion that's come out that, do I want to give post-surgery a course of antibiotics. And even though I've been through what I've been through, I agree with what you're going to be saying now, because I'm looking forward to hearing about the studies that like Sam Most done, etc., that you've mentioned that we're going to go into now. So yeah, I'm going to
Yeah.
let this young gun loose to talk.
Well, yeah. Let me. So I think I should start by saying what are the clinical practice guidelines that have been put out in the last several years. So Lisa Ishii's group, and first of all, both of these surgeons I highly respect, and certainly don't want to take anything away from them. Lisa Ishii put out a paper in 2017, and basically there was one statement, and I'll just kind of quote it here regarding post-operative antibiotics. Quote, when a surgeon chooses to administer perioperative antibiotics for rhinoplasty, he or she should not routinely prescribe antibiotic therapy for duration greater than 24 hours after surgery, as there is a predominance of harm over benefit, end quote. Now, to Lisa's credit, she also kind of lists several exceptions to that rule: revision surgery, complicated rhinoplasty, patients who are receiving these implants, and many others in terms of exceptions. And then Sam Most at Stanford also published a meta-analysis of post-operative antibiotic use in 2019, and quote, pooled evidence from the 5 randomized controlled trials does not support the use of preventative antibiotic therapy in rhinoplasty, end quote. So, it seems pretty clear, right? Post-operative antibiotics do more harm than good. But I think if you kind of if you dive into the data and dive into these papers and dive into the arguments a little bit more, that it's not quite so clear. Although probably many of the tenets or the conclusions that they draw are valid, there are some, I think, important points to make.
Sure.
So I guess if it's okay, Cam, I just think like if we can go through maybe basically individually kind of go through some of these points, we can kind of like tease them out and kind of dive in a little bit deeper.
No, please do, because I think sometimes in this little space, guys say, do not do as I do as what the papers say.
Mm-hmm. All right. That's probably true too. Like if you were to poll people and see what they actually do.
Yeah.
Yeah. And I would say, full disclosure here, for the last probably 6 months, I have not been using post-operative antibiotics. And because actually, I'm going to go on a little tangent here. When I first started thinking about this was at your course in
Okay.
South Africa. I think the Springboks had just won the World Cup, or however you say it,
Yeah. They
and
destroyed England.
they destroyed England. And we were having a chat, just like an informal discussion, and this issue came up. Like someone in the audience had asked, what does the panel do for post-operative antibiotics? And someone in the audience, a South African, had mentioned something about antibiotic resistance in in food production, in the food industry. And that's really kind of what got me thinking about this. And since then, I've been putting together a paper about this topic. And so a lot of what we're discussing here is kind of the arguments that I've been researching, kind of looking into. So anyway, one of the tenets here, one of the ideas is that um, so don't use antibiotics because the incidence of rhinoplasty post-operative infection is low. It is. We all kind of know that. Some studies quote about half of a percent, 0.5%. Those are very old studies, and antibiotics don't help anyway. Well, if you look at Sam Mo's paper, this was a heterogeneous group of 5 randomized controlled trials that were compiled to look at this problem. And if you look at those trials, the antibiotics that were used or looked at in those trials were augmentin, erythromycin, ampicillin, penicillin, and propicillin, which I had actually never even heard of until I read that paper. So the reality is none of these are first line antimicrobial therapy in 2021. Like I don't use any of those. What I use is Keflex, Bactrim on occasion, and clindamycin if I were going to use anything.
Mm-hmm.
So I think that's problem number one. You're using a randomized controlled trial that doesn't use modern antibiotic therapy, prophylactic therapy. So, what conclusions can you draw from it? Of course, this is the problem with all um, all of these kind of compilation studies where you're looking at mixed studies and trying to form a consensus. Um, but however, let's just kind of throw that in the trash bin for now. But what they saw is that if you're using any kind of post-operative antibiotic regimen versus no treatment or placebo, but not perioperative. So perioperative would be the IV antibiotics that you get during the surgery for your listeners. Um, so this is a post-operative antibiotic regimen, so that's after surgery for 5, 7, 10 days versus nothing. The relative risk reduction of a nasal surgical site infection was 0.43, which means that patients taking antibiotics were 57% less likely to develop a nasal surgical site infection than those who took nothing. That's significant. That's not nothing. So basically, what that tells you is that these antibiotics are helpful in preventing surgical site infections. Now, the question then that you would lead to is, well, what kind of antibiotics do you need? Can you just do a perioperative antibiotic, or do you need this full course that goes out over a week? So they looked at that, and so they compared um, pre or perioperative antibiotics to a postoperative course. And what they found was that postoperative antibiotics added less protection with a pooled relative risk of 0.92. But that still means that the postoperative antibiotic course was 8% less likely to get an infection than perioperative. So, I mean, your numbers are going down, and of course, this is kind of all patients, all comers, all types of rhinoplasty, and all these other caveats like the antibiotics that they're using are not the ones that we would use. So you kind of have to take everything with a grain of salt, but still, even with those considerations, postoperative antibiotic group did have less infections. So, it's something to consider, something to think about. The other argument that's often made is that, antibiotic use is going to lead to antibiotic resistance. So, that's obviously true. How big of a problem is this in South Africa?
Yeah, I mean, we linger probably a good 5 or 10 years behind where you guys are, but it is definitely, and especially I think with all the antibiotics that are in food. And in South Africa, we
Exactly.
also have a lot of that, eh?
Yeah. So that's kind of where I was going. Thank you. So the question is, where's the data on this? And I think, you and I and most people would agree that physicians must be thoughtful stewards of antibiotic use and, certainly not give antibiotics without any consideration. But we should also be aware that most of the antibiotic resistance pressure in the world comes from industrial food animal production, which is big agriculture. And so for the next sort of the data in this next part here, I'm really drawing heavily on a review I read from Ellen Silbergeld, and it's actually fascinating for even for medical people and non-medical people alike. She just goes through and kind of talks about all antibiotic use and the history of it in the big agriculture. And so she says, quote, the largest use of antimicrobials worldwide occurs in the production of animals for human consumption of meat, milk, and eggs. Period. So, and if it's true, I mean, anecdotally, I think you and I can think about this, and it makes perfect sense. Like, yes, Cam, you had a horrible infection. You had some antibiotics for that, and I think I might have taken an antibiotic within the last 2 years or something. But these animals are being fed antibiotics every day. You
Yeah.
know, the amount, the tonnage of antibiotics that are used in that industry is mind blowing.
Yeah. Yeah, and then what
So
that can also cause, and that's a whole nother topic for conversation. Yeah.
yeah. So incidentally, kind of it's just some interesting points that I pulled off from this article is that the use of antibiotics in farming began only about 50 to 60 years ago, but it is a major driver for selection and dissemination of resistance in bacteria. There have been many studies linking the development of antibiotic resistant genes in animals and in their bacteria due to the feed or in medicine and subsequent transmission to humans.
No, but I
So
mean,
if it's okay,
like the
go ahead.
feedlots, the grain-fed beef, you want to catch it's horrific. I mean, the animals that are fed and are only in the sick bay number thousands, and it's continual. And yet we love it.
Yeah.
We put it inside our bodies. I don't know what that does to our bodies in terms of cancer, etc. My brother's obviously Farmer Angus. He's really into this stuff. But it's,
Yeah.
we basically try and eat as organic as you can, and that's venison.
Yeah.
That's an
You've
animal
seen
that's
it
been
firsthand.
living in the bush and can't come close to an
Yeah.
antibiotic.
Yeah, exactly. Now things are turning around worldwide, but it is still certainly something that I think is predominant, a predominant cause of resistance. So there are a couple studies that I hope is okay if I can kind of quote them.
Yes, please carry on.
Um, so there's the temporal trend studies, like for example, a study from 2000 examined the introduction of vancomycin in pig production in Netherlands, and then they looked at human fecal samples. And after the introduction of vancomycin, it was closely correlated to an increase in prevalence and resistance in Enterococcus in human samples. So it's just like here's one and here's the other.
Wow.
In Spain, and I think I showed you the graph of this. Perhaps we can put it up on the web or the podcast. But fluoroquinolones were introduced in poultry production in 1993, and the rates of human isolate resistance quickly rose to over 80% 6 years after it was first introduced. Before that, it was right around 5% or less.
Jeez.
So highly correlated.
So
And then there's another study going the other direction. So in Europe, the EU put a ban on the use of feed additive antimicrobials. And then there was a study in Denmark at that time that showed rapid and parallel decrease in the prevalence of antibiotic resistant Enterococcus in pigs. And then furthermore, the prevalence of resistant Enterococci isolates in humans declined in the whole EU over that same time period.
Wow.
So, I mean, it's these are three studies, but there are many others that kind of make this point.
So
And so I think,
if you've got
yeah,
somebody who
pulling
loves having
back,
KFC, chicken,
yeah,
and feedlot pigs, they're in trouble if they can have a rhinoplasty and get an infection.
exactly. So that's the issue is that it increases your community acquired antibiotic resistance just by going to your KFC, which is everywhere. So I think pulling back, the large argument here, Cam, is that yes, physicians must be studious of this issue and um, very cautious when recommending antibiotics. But the reality is that much more damage is caused by the consumption of antibiotics in the food industry than it is by us
Mm.
prescribing. So, kind of both those points there. So the last one I have here is the question is that, well, okay, so are there obvious indications where you absolutely should use
Mm.
post-operative antibiotics? And there is, I think, of course, I have to kind of plug my own paper. So in 2013, I put out a paper looking at the complications associated with implants in the nose in rhinoplasty. And in that study, cases where implants were used, the infection rate was about 12.6%.
Sure.
So that's very high,
Mm.
So I would argue that's a pretty high risk population, and that is a case where I think you could logically advocate for use of postoperative antibiotics. There have been other studies, excuse me. There was a study in 2017 looking at 5,000 rhinoplasties, and they said that the only thing that they could pull out was age over 40, which
Mm.
I don't know. I feel like that's pretty young.
Mm. Yeah. And the young
So,
guns are 40.
um, yeah, that's right. But that was considered a high risk population in that paper. And then I don't know, anecdotally, and Cam, I'd love to hear your thoughts on this. In my practice, I've actually seen this is totally anecdotal, but higher incidence of sort of columella infections with tongue and groove caudal septal extension grafts. So I don't know if that's real or if that's just me kind of, seeing something that's not really there. But that's, I just kind of add that.
That's very interesting. I'm going to go back because I need to actually relook at exactly what is there a correlation between the patients. I don't think it's an old age one. I've actually found, if I think about it, I probably have. You say things come in threes, so sometimes it happens that there's like 3 cases once a year, and then maybe a
Mm-hmm.
year later another 3, and generally young patients, healthy patients, and actually funny enough, most have been outdoors, farmer kind of guys. So I wonder if it's
Oh.
guys who actually are on farms and are more prone to perhaps antibiotic resistance. Because I don't give my patients antibiotics unless it's indicated
Mm-hmm.
for a course after surgery. But I'll definitely go and have a look.
Mm-hmm. Yeah, it'd be interesting. There's probably more story to be told there too. I think revision surgery, that's probably a kind of
Hmm.
an obvious one. You have to kind of use your gestalt sometimes and try to determine who you think is, at risk. Um, so I don't know. I think it's sort of what I come away with after, kind of diving in a little bit deeper into some of this is that I feel that number one, everyone should receive perioperative antibiotics at
I agree
least.
100% with you.
Perioperative meaning IV antibiotics at the time of surgery. Everyone. I think the
Okay,
data
so
is
let's
pretty
just
clear
pause
on
there.
that.
What
Yeah,
type of antibiotics or what dosage do you normally prescribe?
I give 2 grams of Ansef, cefazolin.
Mm-hmm.
If they're penicillin allergic, I will give 500, 900, sorry, 900 of clindamycin.
Mm-hmm.
That is pretty much it. Yeah, those
That's
two.
great.
What do you give?
We normally give them augmentin as
Augmentin.
an
Okay.
IV dose when we're putting them to sleep,
Hmm.
and
Yeah,
tefazolin as well. Depends.
I think that's very reasonable. Yeah. I would also argue that postoperative antibiotics do confer a risk reduction, so they are not superfluous. This
Mm-hmm.
is a real risk, and antibiotics help. Obviously we had that discussion about, well, what kind of antibiotics. We've argued that at least perioperative antibiotics. Kind of we'll get into the rest of it here in just a second, but they need antibiotics and they do help. Agree
Agree.
so far?
Absolutely.
Okay. All right. Um, I would also conclude that uncomplicated primary rhinoplasty does not need postoperative antibiotic prophylaxis unless there are other factors at work.
Agree. Absolutely.
Agree, disagree?
Agree.
Okay. There's actually a really good study. I'm going to mention it here from Regimen in 2005. It was a randomized control study looking at like several hundred um, endonasal rhinoplasties, and these were all primaries, all kind of basic rhinoplasties, and did not confer any kind of benefit. Okay, last one, or a couple of last ones here. When trying to decide whether to use a course of postoperative antibiotics, pros and cons should be considered for kind of each case individually. Agree or disagree?
Absolutely agree.
Yep. And I think these are guidelines, of course, and they have to be applied individually to each case. It is right to be cautious about the development of antibiotic resistance and perform good antibiotic stewardship. However, we should realistically consider the impact of a 5 to 7 day course of antibiotics in some of our patients versus that of the big agricultural industries.
Yes. Very good point. Agree.
Yeah, I what I kind of want to say there is that there's a high cost of surgical site infections to both patient and doctor if they occur. And certainly we don't want to cause antibiotic resistance. We don't want to cause things like Clostridium difficile infections. But the real risk of that is, I think, lower than is kind of commonly touted in our specialty. So I wouldn't want any of our listeners or anyone to feel bad about using antibiotics if you feel like your patients will benefit.
Yeah, that's brilliant. It's an absolute right
Is
point.
that fair?
Fair.
Okay.
So
Yeah, that's all I got.
no. So a couple of things from my side. So one of the things I would consider in a primary to give a course of antibiotics after surgery is if I've also done some sinus surgery and I've put dual
Mm,
splints in the nose. even though I'm encouraging the
it's
patient
packing.
to flush it, but they're packed because I'm concerned that I might be affecting the sinus drainage pathway. So that's one point. But then, so what I then do is, if there are four things that in my practice, so the patient's going to get a dose of antibiotics when they go to sleep. But beforehand, I want to give them, they get a little bottle of chlorhexidine to wash their hair and their face the night before surgery and the morning of surgery. The second thing that I do for them is I give them a little tube of antibiotic ointment to put on their nose after the operation. And then the last thing is that when the site is sterilized before surgery, we use betadine to do that. And for me, if I can, so I've got the patient prepared by cleaning their face beforehand, cleaning it in surgery, giving them a tube of antibiotic ointment for afterwards, and getting them to flush their nose out with saline. Hopefully those things can decrease the risk of surgical site infection. What are your thoughts about that? Do you agree or disagree?
I totally agree with those. Are, I think, sort of objectively good measures to do. There's certainly little downside to doing them. I can't tell you if there's been evidence to support that, but I mean, I use betadine for every one of my patients, and I think that it is a good thing to do. I don't see a downside to doing it. It can only help. Yeah, I would love to do a study to kind of determine if that has any effect, but certainly doesn't hurt, and it's a very inexpensive thing to do.
No, that's awesome. Okay, Andy, for the last part, I want to ask you now. Okay, so what happens when you do get a surgical site infection?
Yeah, I use Bactrim right away.
Okay.
So Bactrim in the United States, at least, is a good antimicrobial to cover a methicillin-resistant Staph aureus, and it seems to be very well tolerated. It's relatively inexpensive, so that's kind of my first line of defense. Obviously, I guess I'll step back one second. If you do have fluctuants, if there's something that you feel should be drained, that's obviously the most important thing to do is drain it. So I have done that. I've done drainages in the clinic, and then I'll take an 18 gauge angiocath, the soft catheters. I'll stick it right in my incision that I made in the septum and just kind of irrigate it out. Patients do not love that. I'll let you know.
Yeah.
But I think it is helpful, at least to kind of get the infection under control. And then, as I mentioned, Bactrim for about a week.
Yeah. Well, that's awesome.
What would you do?
Absolutely, and I'll get a bit nervous at the same time. I don't like it, but so my tolerance for taking someone to theatre and cleaning up properly is very low.
Yeah.
So you got to.
That's what's nice, kind of in the setting that you're building is having a theater in house. I think it would be certainly not a bad thing to do. There's a little more inertia for me to do that, to try to find time in the OR and blah blah blah, and it may be 10 p.m. by the time I'm getting in there. So, yeah, it's a bit of an issue.
Yeah, awesome. Well, Andy, thanks, man. I so appreciate your time and the wise words. And we give a shout out again to Vectra. I don't know if you use them. They're helpful.
Actually, I have used them. I don't have them at my university, but I would love to. I think they do make a fantastic product.
Yeah. So please, so you can actually send an email to me with the name The Rhinoplasty Podcast and get a nice discount on Vectra. So
all right.
See what we can do for the listeners out there.
All right.
Great.
Awesome,
well, Andy, thanks again for your time, and have a lovely rest of your day.
You too, Cam. Have a good day.